Hi everyone, if we could just get this session going. Nice to see you here in the technical session. So there's lots of good science going on next door, but it's great to see that we can also do things other ways. There's ways we can help clinicians, there's ways we can help transplanters and the people infusing cords and things like that. And this is really what this session's trying to cover. So with that, we'll segue into the first presentation is from Dr. Chloe Anthias. She's a transplant coordinator at the Royal Marsden Hospital in London, UK, but she also works as a consultant for Anti-Nolan Stem Cell Registry as well. She's got a recorded talk, unfortunately, because she couldn't make it, but she's going to talk you through the practical challenges in clinical cord blood transplantation and how the registries and cord banks can help.
Hi, my name's Chloe Anthias, and I'm going to be talking today about some of the practical challenges in clinical cord blood transplantation and try to give you an idea about how potentially some of the registries and cord banks can help. I'd like to thank the organisers for the invitation to give this talk, and I'm really sorry that I can't be there in person to present. And just a little bit about my background. I'm a clinical transplant consultant. I work at the Royal Marsden Hospital in the UK, and I also work as a donor health consultant at the Anti-Nolan Donor Registry. I'm definitely enthusiastic about cord blood transplant, and although the centre that I work at maybe doesn't do huge numbers of cord transplants compared to, for example, some of the US centres, we are the biggest cord centre in the UK. So we do between 60 and 70 allografts from any source, and before the COVID pandemic we were doing about 8 cord transplants a year, but we've really increased our confidence in doing those over the last couple of years and shown good results, so we're now doing between 15 and 20 a year. So I'm sure everyone here is very familiar with some of the major advantages of cord blood transplantation, but I'm just going to briefly touch on some of the reasons that we are particularly enthusiastic about them in our centre. Firstly, we have a very ethnically diverse population that we serve, and we know that cord blood massively extends transplant access to ethnic minority patients. The second reason that we like cord is that we know that cord has excellent results in the highest risk patients, and we serve a very high risk transplant population because we're a cancer centre, so we have a lot of patients with treatment-related myelodysplasia and acute myeloid leukemia who have very high-risk disease, and we know that particularly the highest-risk patients benefit from the excellent graft versus leukemia effect that you get when you use cord as a graft source. And I'm sure many of you are familiar with this publication published about 6 years ago, showing that compared to adult donor graft sources, cord is particularly good in patients who go into transplant with minimal residual disease and have much lower risk of relapse using cord than an 8 out of 8 or a 7 out of 8 unrelated donor. And the other reason that we really like using cord is that cord recipients have very low levels of chronic GVHD. So in many ways it's a perfect graft source because we have an excellent anti-leukemia effect, but without the high rates of chronic GVHD that we would see if we were using, for example, a mismatched unrelated donor. But there are a number of historic problems with cord. Firstly, the low number of stem cells leading to slow engraftment and high transplant-related mortality. Secondly, although rates of chronic GVHD are low, historically there have been high rates of acute GVHD and pre-engraftment syndrome than we would typically see, particularly in the UK where we tend to do T-repleted unrelated donor transplants, and then of course the issue of expense. And some of these issues have been addressed. These are just engraftment data from my centre, where we have been adopting the more recent guidelines about cord selection, and as a result we've shown that the cell numbers that we've been using in our more recent cords have increased, and although this difference isn't statistically significant when we look at our engraftment by era, it is our days to engraftment are getting shorter, and we're now down to a median of 18 days to engraftment, which is not as dissimilar as previously to our unrelated donor or siblings, who have a median of 15 days to engraftment. And our rates of primary graft failure currently are about 5%. So although this is still prolonged compared to UDS and SIB transplants, as we're selecting bigger units and as we're particularly considering CD34 doses, engraftment rates have improved, and the same thing's been shown in some of the other big centres. Another advance has been changes in transplant conditioning, and these are data just showing excellent results from Juliet Barker's publication in Blood Advances in 2020 of their results from their MIDI protocol. So MIDI conditioning being higher intensity than the typical reduced intensity conditioning that we used to use, and reducing the relapse rate in patients who are fit enough to have slightly higher intensity conditioning. And the other advance we've seen really is in evidence-based guidelines to help transplant centres with cord selection, which we certainly find very helpful. We currently use the UK BISHI guidelines from 2021, but these are very similar, as you'll see, to NMDP and ASTCT guidelines, and a gradual increasing focus on CD34 dose and higher TNC doses to aid engraftment. But despite these advances and the fact that with current transplant strategies, several specialist centres have really shown excellent results. You can see here these are EBMT activity survey data showing in green cord numbers, which remain extremely low compared to haploidentical or any other graft sources, basically. So thinking about some of the reasons that cord blood use remains low, well, we know that slow engraftment and high early TRM certainly were an issue initially, but they are improving, and certainly experienced centres have shown much lower rates of TRM than early studies, and high rates of acute GVHD definitely still exist compared to, for example, in the UK, where we use T-deplete transplants, but again, improvements have been made with changes to conditioning and immunosuppressive treatment. Expense is obviously still an issue, but I think one of the main problems is lack of centre experience and confidence, and centres being able to gain enough experience in cord when they perhaps already are doing other alternative donor transplants like haploidentical donors. And I don't think that this is something that can be addressed particularly easily. It probably needs a multifaceted approach, but I'm just going to try and touch on some of the kind of real world experience that we have in our centre, and how, I guess, we have changed from being relatively unconfident to becoming more confident, and maybe even if centres aren't going to switch around and go from being haploidentical centres to being cord centres, maybe cord centres that already do some cords can, like us, increase their numbers as they develop more expertise and become more supported. I'm just going to talk through the process at our centre and the challenges that we have sort of faced at each stage. So when we think about the first step, donor selection, this is just an example of what our typical unrelated donor selection folder would look like. We just store every patient on our hard drive, and they have their own folder with all the potential donors in. This is a potential unrelated donor folder, so you can see we would have, for example, the patient's tissue typing, we'd have their search report, we'd have a couple of different possible unrelated donors, we'd have their virology, and we'd have maybe a sibling. And so we can look at that, see very quickly, okay, there's a couple of different donors that we've got to look at. If we then click on one of the unrelated donors, we would see that we have a standard unrelated donor HLA typing report that we would get from the Anthony Nolan, and we can see the unrelated donors typing, and then we have a pretty foolproof interpretation down here where it says the potential unrelated donor has a detectable mismatch for HLA-DPB1, permissive when compared to the patient at the level of typing performed. So we know that they're a 10 out of 10 HLA match. If you consider HLA-DPB1 as we do at our centre, this is an 11 out of 12 permissive HLA match with the patient. They are CMV and ABO blood group match. So anybody can obviously read that and be fairly confident about what they're talking about. If we then request that donor, what we eventually get back from the registry after the donors had their medical, etc., is a standardised donor clearance, and that will just tick off all the virology, confirming that the patient doesn't have any positive IDMs, and basically signing off that the donor is able to be cleared and that they're suitable and eligible. Occasionally we might get a comment that they've had, I don't know, a tattoo a few weeks ago or something else that we may need to consider, but generally the donor will be cleared, we'll get the confirmation of the clearance, and we'll be able to be very reassured by that, I guess. When we have a patient that we're considering a cord on, this is what their typical donor selection folder would be like. And you can see obviously that when you're in a busy clinic, you're being asked to look at a patient's potential best donor, then it's just a lot to go through. It becomes very time consuming. And so here we can see, for example, that there are a number of different cord reports. We'll have to think about HLA, whether the patient has any HLA antibodies. So we'll have a couple of HLA antibody reports. We'll have the cord summary table. We might have some the patient's tissue typing, maybe some unrelated donors who weren't a good enough match. But there's always going to be a lot of different cord reports that we'll be considering. And we have both the checklist that we get from the Anthony Nolan and the cord qualifying forms, and there's just a lot of paperwork basically. When we then click on our cord reports, you can see instantly that there's just various different layouts, and while that's not necessarily a problem because all of the information that we need is there, it just takes time when there's a patient sitting in front of you in clinic and you're not particularly experienced at looking at these. Just to get the information that you need takes longer and requires more interpretation, I guess, than the reports we get back on. When you then want to get around to shipping a cord, you obviously need to see the pre-release testing and reports before you would be happy to request shipment. And again, it just takes a little bit of time and expertise to interpret some of the pre-release quality tests. Not a huge amount of expertise, and I'm sure if you're from a cord blood bank background, you can look at this instantly and see whether you think the cord would be acceptable or not. But the results are often presented differently. There are some things that are not present on every cord report. For example, here the CFU is reported as growth. In other reports, we would be given a quantification, and sometimes we would get back, for example, just a CD34 viability. Sometimes we'll get a number as well. And it's something that I think certainly clinicians that aren't used to doing cords frequently are not necessarily completely confident with and don't necessarily feel comfortable. And we actually end up cancelling about one or more cord in about 10% of our patients on the pre-release quality testing results. And I will show you some examples of that, and it may be that experts here think that we should or could have perhaps have accepted some of those cords, but it's partly a confidence thing and needing to be sure that the cord that you're requesting for your patient is going to be adequate, basically. So I'm going to go through some cases now that illustrate some of the points that I've just tried to make. So in this first case, we have a patient who is 60, fairly typical weight, 74 kilos. the transplant is urgent because he's pancytopenic, he hasn't recovered his counts after chemotherapy. There are no obvious sibling or unrelated donors, but he's got good cords. So these are some of the data on the 2 European cords that we requested. And we're very happy because quite unusually in our centre with our population, we had 2 7 out of 8 cords, so very good matches. So we were pretty happy with those until we received back our pre-release test. So this is our first cord and we got TNC viability of 47%, CD34 viability of 91%, but this was the CFU data. And although these results are above FACT criteria for release, the clinical team weren't sure what to do because there were no total CD34 or TNC post-thaw data, so we couldn't calculate recoveries, and we were a bit worried about the CFU dose. So as we often do in these situations, we phoned Roger at the Anthony Nolan Cord Blood Bank and discussed it with him, and eventually made the decision to cancel the shipment of this cord. By this point, our transplant was urgent, so we did a repeat cord search, specifically looking for a decent enough UK unit to replace it. So we did manage to identify another cord, so this is cord 3, and this was a 5 out of 8 unit, so a less good match, but we were, given the patient's disease, we were quite happy to accept a 5 out of 8 match with reasonable TNC and CD34 doses. We then received the pre-release results for our second cord, and with this cord we were concerned because when we calculated the clon E, it was less than 10%, which is our usual cutoff. And so we then cancelled that shipment and asked for yet another cord. So this is the 4th cord, a 5 out of 8 UK cord, again with acceptable TNC and CD34 doses. After that, we got our quality testing back on our 3rd cord, the first UK replacement cord, and the UK cord bank had actually advised us not to use this unit because the quality results were suboptimal, and we therefore went back to our second cord and reinstated that because we were running out of options at this point and it was shipped. So we ended up transplanting our patient 1 month later than we'd originally planned to. He engrafted on day 12, so excellent engraftment. He did develop some grade 2 skin and liver GVHD, required a short course of steroids. He was MRD positive 2 months after his transplant, but then became MRD negative, so showing an excellent graft versus leukemia effect as we'd hope for, and he's now doing really, really well and just occasionally needs to use topical steroids for some mild chronic GVHD of his skin. So an excellent outcome, but definitely stressful and time-consuming for the clinical team. And if we hadn't have had the support of Anthony Nolan, I think we would have ended up reverting to a less favourable donor option, and that he would have done less well because he was MRD positive after his transplant. And we know that cord really is the best graft source in that situation. And although his transplant was delayed, it was definitely less of a delay than we'd have had if we'd have replaced with an unrelated donor. So our second case is a 60-year-old female who was treated for treatment-related MDS with an excess of blasts, so again a high-risk patient. And when we did her cord search, we were pretty happy with the results. We had 2 cords from FACT-accredited banks. One was a 5 out of 8, but 7 out of 8 in the HVG direction, and the other was a 5 out of 8. We requested double cord shipment and planned for a transplant date of the 26th of January this year. When we got back our cord report check, the first cord was noted to be over 3 bags and was missing information on red cell reduction, so we requested that additional data. The first dilemma came when we then got a positive HLA antibody screen on our patient, and the patient was noted to have HLA antibodies to cord2, not a particularly high MFI, but was also noted that cord 1 didn't have a DRB345 typing, so that was requested with extended typing, and we then repeated the HLA antibody screen, found no HLA antibodies to cord 2, but she'd now developed a anti-B2708 to our backup cord with an MFI of 3000, which is not a huge MFI, but it is around the level that we start to get slightly. Our next dilemma occurred when we got our pre-release results back. So on our first cord, the TNC viability was low. It was 39.4% by 7AAD and 55% by trypan blue. And the CD34 viability was a little lower than we would have hoped for as well. So we sought advice from the Anti-Nolan Cord Blood Bank again, and they did some additional calculations based on the pre-freeze TNC and the frozen bag volume, and calculated that the TNC recovery was actually excellent. So we decided to use that cord. The next dilemma we had that we needed help with was that we found that cord 1 had a high hematocrit on the additional information that we'd requested. So the hematocrit ended up being calculated at 60.6%, with 24 mils of red cells, which equated to 0.4 mils per kilo for a 60 kilogram patient. And the red cell processing was noted to have only reduced it by 2/3. And the Bishop guidelines advise accepting units with a hematocrit of less than 40%, and our transplant centre uses 0.25 mils per kilo as a safe threshold, and we can't wash units at our centre, unfortunately. We simply can't do that, and so we then ended up cancelling this unit for shipment after all. We requested an alternative European unit and a domestic backup unit, and then got our final unit report back for cord 3, showing excellent TNC recovery and quality results. And the hematocrit was a bit high, but the total volume was much lower than the other cord, and we decided that was acceptable as it was only just over our threshold. So we shipped the 2 cords with a transplant delay of approximately 2 weeks. And again, the patient engrafted well, and there were no other clinical issues. But again, it was very time consuming for the clinical team. We required support and discussion between our stem cell lab and the Anti-Nolan Cord Blood Bank. But there was only a short delay to transplant, and it wasn't clinically significant at all. So a good outcome for the patient. So those are just 2 examples of where we have needed support and some of the issues that we faced. Other common issues that happen are we get sometimes confused about various approaches to reservation fees, and we're never sure whether to reserve cords or not, or whether we're going to be, at what point we're going to be charged. We note that there are varied cord blood procedures regarding when quality testing is done, whether it's done when you request a reservation or at shipment. And we've also struggled being English speakers who tend to panic as soon as we see any foreign language, with occasional bits of foreign language in some of the reports. And for example, one issue we had recently was that the thawing instructions were in a different language, but they said that they think that a person used to thawing stem cells should be able to understand the text. So what can individual registries and cord blood banks do? Well, one of the super helpful things that the Anti-Nolan does for us is providing the summary tables to aid our selection. When I was the transplant coordinator at my centre some 10 years ago, I used to have to make these myself, which was very time consuming. I was always worried about inaccuracy, so it's wonderful having the registry making them for us. The next thing they do to help is that when we do a search, particularly over the period of the pandemic, as well as showing us the top units. They show where there are additional UK units, so that we know that we've got fairly instantaneous backups if we need them. They also provide us with a very helpful cord blood unit report check to highlight where there are any issues that we might want to be asking for additional information, which again is really, really helpful, and flags any issues that we might have further down the line so that we can address those up front. And really helpfully, they provide us with a helpline for lab report questions. So they now have a dedicated service for this. And I do think that many clinicians need support from either a registry or domestic cord banks to feel comfortable when they're not super experienced in this area. We're very happy with what to do with when patients have disease going into their transplant, have nasty infections, have suboptimal reports on their kidneys or heart, all of which are things that are potentially, worse for the patient overall, but we are just not very comfortable with cord quality results with our. So what could cord blood banks and registries do to help? Well, the first thing is if cord reports were standardised, I think it would just really help us access the data we need quickly and save time. But I realise that's obviously not an easy thing to get everyone to change to do. I think standardising the pre-release testing that's done and the points at which charging is happening. But I think one of the biggest things that we could do internationally is helping disseminate excellent cord results, as we are at this conference, and potentially also maybe cord blood networks could help establish national and international networks where expert cord centres can provide support to less experienced centres. I think that would be key. So I'm going to leave it there, and thank you very much for listening, and to the organisers for inviting me to give this talk. And again, I'm sorry I can't be there to join you for questions, etc.
Okay, well, if you think of anything else, we can come back to it towards the end. In the meantime, I think in which case we'll segue into the next talk. This is from Minoko Takanashi around the role of the cord blood banks in unrelated stem cell transplantation in Japan. Minoko works for the Japanese Red Cross. She's a scientist in hematology. She's been there since 1993 and has been working for around about 30 years in this area, setting up standard operating procedures and working with government to ensure that everything in Japan can be as slick as possible. So if we can go to that presentation now, please.
Hello, I'm Minoko Takanashi. I began work to build a cord blood bank at the Japanese Red Cross in 1994. Since then, cord blood has become a major source of stem cell transplantation in Japan. I'm happy to share my experiences with you. This graph shows the number of allogenic transplantations in Japan. The numbers come from the Unified Stem Cell Transplantation Registry. Cord blood transplantations, the pale green at the bottom, have become important among the sources of hematopoietic stem cells. This shows the ratio of the unrelated transplantations with patients 15 years old and younger. Cord blood transplants are about 1/3. This is for patients aged from 16 to 50 years old. What is unique in Japan is that even for adult patients, cord blood is an important source of stem cells. In the general population, age is a risk factor for hematological malignancy. With patients over 50 years old of age, leukemia often evolves from myelodysplastic syndrome, and they cannot wait long for a transplantation. So, cord blood is a good choice for them. Cord blood is said to be an alternative source for stem cell transplantation. In the early years, and even still now, cord blood transplantations had been for patients at a more advanced stage of their disease. When patients had a stable disease, they were more likely given a bone marrow or a peripheral blood stem cell transplant. Patients with higher risk, for example, those who could not wait to find a bone marrow match, were given a cord blood transplant. Therefore, the outcomes would be expected to be worse. Gradually, the advanced standard risk ratio decreased as reports show that the timing of transplantation is generally important for better results. This graph is for unrelated transplantations. Since 2016, the number of cord blood transplantations has been higher than the number of bone marrow and PBSC transplantations combined. The increase in 2020 for cord blood transplants was because of COVID-19. The coordination for bone marrow and PBSC donors and the patients was difficult when hospitals were under stress with infection control. This shows the age of cord blood recipients. The increase in cord blood transplantation is coming from its use for adult patients. HLA matching for our cord blood transplants. Most of the patients receive 4 out of 6 antigen-matched cord blood. So, 2 antigen mismatches are common. In allele matching, 3 out of 8 mismatches is the majority, about 1/3 of the total cases, followed by 4 out of 8 mismatches. This is the patient's body weight. The average body weight of adult women in Japan is 54 kilograms and 67 kilograms for men. The cord blood banks are trying to preserve units with high total nucleated cells, TNCs, for heavy patients. In Japan, we have 6 public cord blood banks. We have been approved by the Ministry of Health, Labor and Welfare. 4 of them are managed by the Japanese Red Cross. The number of cord blood units that are ready for transplantation and on our donor search system was 9,662 on August 1st. This slide shows our practice. We ask the obstetrics clinics to recruit donors and to get informed consent. They collect the cord blood at childbirth, and we ask a delivery service to carry the cord blood, the mother's blood sample, and the documents to the cord blood bank. When the cell number and documents are satisfactory, the cord blood bank processes and cryopreserves it. When all the test data is okay, we send out a follow-up questionnaire to the mother, asking if she had any infection after the childbirth, if the baby is growing up healthy, and to make sure there are no abnormalities being indicated. We ask the mothers to inform us if there are any new problems, and we have to keep the cord blood unit for at least 9 months before we register the data to the donor search system. This is the number of cord blood units that the cord blood banks have uploaded to the donor search system. The colors show the total nucleated cells, TNC, measured before freezing. In the first years, we tried to increase the total number of units. Then we shifted to have units with a higher TNC count. About 10 to 20% of collected cord blood is processed and cryopreserved nowadays. This shows the number of units used for transplantations. The transplant centers continue to choose units with a higher TNC count. The units with higher TNC turn over very fast. So the majority of the units left in the search system are with a relatively low TNC count. Around 70% of the units used for transplantation were shipped to transplant centers within 1 year after they had been made available in the search system. Most of the units chosen by the transplant centers had been in the search system less than 5 years. Units with lower TNC counts were used, though, for pediatric patients. This shows newly registered unit with colors for CD34 counts. Recently, more physicians choose the unit by the CD34 count. So cord blood banks began to count CD34 cells before beginning the processing of the unit. We are trying to store units with a higher number of CD34 cells. This shows the units used for transplantations. In recent years, the units with higher CD34 counts are increasingly making up a higher ratio of the units selected. For units with CD34 of more than 7 times 10 to the 6th, more units are being used than the number of cord blood banks preserved and included into the search system. It is hard for the banks to increase the number of units available with the high CD34 counts. This graph shows the bank size in Japan with colors for CD34. We don't have many units with a high CD34 count. Unlike TNC, it might take a long time, but the cord blood banks will try to change the ratio of units with higher CD34 counts. This shows the difference of the ratio of cell counts in the cord blood unit for different age groups. Units with low TNC or CD34 counts are used, although for smaller patients. Pediatric patients tend to be transplanted with units that have better HLA matching, although with smaller cell counts. Japan is a small island nation at the end of a large continent, and there hasn't been much migration to the country, so the HLA haplotype distribution is quite less diversified. The most common haplotype can be found in more than 8% of the population. For our population, when you accept a 4 out of 6 HLA match for the antigen level, most of us can find a cord blood from 1,600 units. If we need 5 out of 6 HLA matching, we need 10,000 units to find a matched cord blood. So we agreed to keep the total bank size for all of the country at 10,000 units. This shows our workload. We need about 2,500 units added to the search system every year. About 1,400 units will be used for transplantations, and as we keep the units for 10 years in the search system, 1,000 extra units will maintain the bank size at 10,000. About 800,000 babies are born a year in the country, but we have only 100 hospitals and clinics that have contracts with the public cord blood banks. Yearly collection at childbirth is around 20,000. Since 1999, all of the public cord blood banks, the hematologists, obstetricians, infection regulators, lawyers, and patient support groups have met monthly to discuss problems and exchange information and to standardize our practice. In 2012, a new law was made, and the roles of the government and the Japanese Red Cross became clear. Since 2014, my section of the Japanese Red Cross has been conducting the communication between the various organizations and related parties. We also keep our old relationships between the stakeholders. We work together with the Ministry of Health, Labor, and Welfare, the Japanese Society for Transplantation and Cell Therapy, the Japan Maradona Program, cord blood banks, of course, and patient support groups. Some meetings we hold work to connect transplant physicians, obstetricians, and patients with cord blood banks. The Cord Blood Technical Council works to ensure the quality of cord blood. Every year, one of the banks prepares aliquots of processed cord blood, freezes them, and sends them out to other banks. The results of cell counts after thawing are shared amongst the cord blood banks and the Technical Council. The data shared includes the TNC, nucleated RBC, CD34 cells, the viability of CD45 and CD34 cells, CFU-GM, BFU-E, CFU mix, and total CFU. At the same time, each cord blood bank has to evaluate more than 1% of their cryopreserved units. This is from 6 banks. A small bank gives only 2 sets of data, a large bank gives 8. The post-thaw data is compared with the pre-freeze counts and shared. This figure shows the differences of test results for the TNC count between post-thaw samples from the bag and from the segment. The blue triangle shows the after-thaw data compared to the pre-freeze data using the sample from the bag. The red circle is for the segment. Since the transplant center physicians receive the post-thaw data from the segment, we try to show them how close or different they can expect it to be from the actual bag. And this is for CD34 viability. The transplant center physicians choose a unit based on the pre-freeze data and receive from the cord blood bank the post-thaw data of the segment. Apart from the meetings we hold, we manage an IT system for unrelated transplantations. The donor search system for cord blood gives results that looks like this. We currently consider only the antigen level of HLA-A, B, and DR. But after many discussions with physicians and HL specialists, we are going to change the search system to handle 4 loci, including HLC, and the allele level starting next year. We will also change the algorithm to use the same one for cord blood, bone marrow, and peripheral blood donors, together in one search system. Here, only one unit can be booked for one patient. Communication with the patients and their support groups, physicians, obstetricians, midwives, and other people working together is the foundation of the cord blood bank. I deeply thank the donors and their families who donate the cord blood to us. This is a photo of the sticker we made in the spring of 2020, when the total number of cord blood transplantations reached 20,000. Working for cord blood banking is a pleasure for me. Thank you for listening.
Okay, is anybody going to comment? Any comments on Minoko's presentation at all? Just while you're thinking about it, as an aside from myself, I guess the takeaway points from that was the inventory there was only 10,000 with 1,200 transplants a year. That's a phenomenal turnover of cord, but it also seems to shine a light on how to be very efficient in that inventory is not large, it's high TNC, it's good quality CD34, so you don't need hundreds of thousands of cords, you just need an efficient cord blood bank. And I guess also that kind of collaboration that she showed there between the government, the transplant centres, the regulators is also key to being efficient, because if you know what your patients need, what your end users need, you don't need to spend millions and millions of pounds on an enormous inventory if that's not fit for purpose. Okay, so for those of you that don't know me, my name's Dr. Roger Horton. I work at the Antinodal and Cell Therapy Centre. My role is really twofold. First off, I deal with our kind of local regulator and accreditor and ensure that we're compliant for both of them. But chiefly, I'm passionate around any transplant centre should be able to use cord blood for their patient, irrespective of their level of experience. And it's up to us to provide the support network to allow that to happen, so that patients don't get a suboptimal graft for their condition simply because of a lack of experience. Let's see if the technology works. Ooh, good, it does, cool. So, how can we maximize patient benefit? Simply put, we can't work in isolation. I think we just saw that in Minoko's presentation there. Close collaboration with the registries, the transplant centres, gives us that vital, broader context for our own activities to make sure that we are doing the right thing for our customers. It's vital insight that we can't afford to miss. So that then allows us to be as effective as possible as we can be for our patients. Again, efficiency is key. If we're not using our budgets as wisely as possible, then there's a risk that the cord blood banks won't be there to help those patients. So what's the status quo? This is the WMDA Global Trends Report, which I'm sure you're familiar. Between 1997 and 2001, there's been more than 61,000 unrelated cord blood transplants. Cord provisions were decreasing in the previous 3 years prior to 2019, but we saw a little bit of an increase. Unfortunately, then COVID came along and rather put the kibosh on that, so it dropped in 2020, and things are still sorting themselves out in 2021. It's actually, if you look at that graph, there was a kind of a 2,000 patient increase in PBSC in 2021, and kind of bone marrow and cord were the kind of losers out in that section. But we're still looking at over 2,500 cord transplants shipped annually. Importantly, 40% of those are shipped with at least 2 mismatches, and that's critical for our patients, which are kind of HLA diverse and need that ability to have a graft that can deal with that degree of mismatch. So it accounts for around about 5 to 10% of transplant. So what's the issue then? It remains an important graft source, and if we're still doing 2,500 a year, then what's the problem? Well, the issue being there is 2,500 globally. So with that utilization rate, each transplant center is only doing a relatively low number of procedures each year, with possibly the exception of a few specialist centers. Certainly we see this in the US, in that a lot of utilization is focused in on kind of 4 or 5 users. Ourselves in the UK, there's probably 3 or 4 centers that account for a lot of it. So the problem there then is that the clinical teams dealing with the search, selection, and all the rest of it become unfamiliar with the nuances of cord when they're suddenly called upon to work one up. It's a shock to the system. They're not familiar with the data. And the problem is that then leads to a risk of loss in expertise within the transplant community, and also a loss of patient benefit as well. So this is just some of our data from Auntie Nolan here that you can see, looking at the number of cords in green and the number of patients at the top there in grey. And we were seeing a kind of a downturn. We were down to sort of 54 patients using 83 cords in the UK, with about 5 patients a month being treated. And we had a feeling that maybe it was some of that unfamiliarity. So it wasn't just cord as a graft, but it was the unfamiliarity that led to it being perceived as difficult to do cord transplant. And I think, again, you could probably see that from Dr. Anthias's presentation as well, just the sheer volume of information that the selection team has to deal with, as opposed to when they're doing an adult search. So what we're going to do about it? Well, in the UK, we decided to set up a joint Auntie Nolan and HSBT cord support program, with the idea being that we could deliver information, training, and advice to transplant centres as it was needed. I might add that all this was set up for free, because any gains you get from doing this you get far more from additional cord blood transplants than you do from charging consultancy fees or things like that. So we set all this up for free. We made sure it was readily accessible. It wasn't difficult to do because, as I said earlier in some of the comments, we were just using our own experts but pointing them in a different direction. So instead of interpreting our own in-house data, we started to offer the ability to interpret other people's data. Or if we didn't know that bank's procedures, we know the people, a lot of whom are at this conference. You can email them and say, does that test data look good to you? How does that compare with your own in-house ranges? And then we can give that advice back to the transplant centres and take that difficulty out of it. So, just as a kind of a summary, I suppose, of the impact that we've had so far in cord support, we started doing it just in financial year 17-18, which is third from left there. As you can see, we've now gone from 54 patients and 83 cords to 109 patients and 147 cords in the UK over the last 4 or 5 years. Now, as I said, none of this was expensive. None of it required refurbishment of clean rooms or huge investment in new scientific protocols. This was simply reducing the administrative and interpretive burden of the cord blood process. Oops, it started there, yeah. I shouldn't do animations, they only catch me out. So, just to summarise, it's better outcomes with less stress for the teams involved in the selection and the administration. Primarily in the UK, it tends to be the bone marrow transplant coordinators that cop the brunt of this, because the clinical teams don't necessarily lead. It'll be the HLA labs and the transplant coordinators that are trying to sift through all this information to make the right recommendation. Since the inception of the cord programme, the number of patients treated in the UK has effectively doubled for cord transplant. There's been a 77% increase in the number of cords used for transplant, and commensurately our own bank has actually increased its shipments by 30-odd% as well. So you can see there's a kind of a bit of a gap there in that we're not supplying everything in this increase because everybody else's unmet need. So a good proportion of this is additional imports from abroad as well. So roughly it stacks up that we get just shy of 40% of our cord from the US. The two internal banks provide about another 36%, and then a lot of it comes from France, Germany, Spain, Canada, North America. So the work we're doing is pushing up utilization full stop. So if everybody does this, we can all push up everyone's utilization. It's not just your own bank, it just keeps the whole process going. The other important thing in this is that the transplant centres don't feel isolated in the decision making, because if they're not familiar with data, as Chloe stated again, it's the confidence to make that decision. And if you're not familiar with the graft as we are as bankers, then that can be difficult. So just a little bit of feedback. A transplant centre in the Northwest said that we don't just provide a service, we're regarded as part of the local team. So they'll happily pick up the phone and have a chat with us about a number of grafts, be they ours or international, to work out what's going to happen. And it's about building that relationship. Another transplant centre in the Southwest said that we feel so supported. It's good to know that you're there with your experience to help at any step. And again, that's important. You need to identify your customers and what they need. So you've got your specialist centres. Your specialist centres know what they're doing for search and selection. What they need is a really fast, quick, efficient service. But the users below that may use 5 or 6 cords a year or only 1 or 2 cords a year need a very different service. That needs to be a hand-holding process right the way through from search and selection all the way through to on the ward, because then they know that they can do it without the risk of misinterpreting something or delaying transplant simply because they're not confident in what they're doing. So in short, the impact of the programme has been great for both the patients and our own sustainability. The question is, how do we build on this? What's next? So the idea of a UK cord initiative was created with a number of aims to build on the prior work that we'd already done. So chiefly reverse the decline in use of cord transplant and make sure it's available for future patients. Create a national cord community to promote cord transplantation in the UK and ensure that there is multi-centre collaboration across the UK to do that. To bring together the key stakeholders in transplantation to push for a common objective. To review and update our own support services, including the cord support programme, which I've spoken about, the cord blood unit service advisory panel, which is provided by the histocompatibility compatibility community in the UK, and also the cord blood working group. To collaborate with leading international experts is also essential, because there is significant expertise over here that we can learn a great deal from. We need to develop consensus uniform guidelines and standardised practice as well, so there isn't regional variation, because standard of care can vary. Even in a small country like the UK, that you'll see vastly different outcomes depending on which part of the country you're in, depending upon a centre's level of expertise. In order to prevent that, we need to facilitate close communication between the transplant centres and the cord banks as well, to improve both banking practice, but also the unit selection and optimise patient care. We need to facilitate closer collaboration as well between the adult centres and the paediatric centres. The paediatric centres, a lot of them have an awful lot of experience in cord blood transplant, and some of that can be translated across to those adult patients to again boost outcomes. We need to extend, facilitate and support CB transplantation. UKTC is not currently performing it, and we need to educate and train the search coordinators and junior clinicians in the practice of cord transplantation, as mentioned by Juliet there as well, to ensure that we can remove that burden and we've got experts in that area. We need to develop novel clinical trials as well and innovate on the research side in order to contribute to academic output and show that cord really is a graft of interest. And, you know, if we came to a transplanter now and said, I've got this new drug, it's got 75% survival from AML at 5 years, they'd bite your arm off. As soon as you tell them it's cord blood, oh, why? We've got to get out there. Every other drug has a sales team, someone to show people how it's good, how to use it, and we need to do that. That's where I guess creating the network of transplant centres that can investigate those next generation protocols comes in, and we can also create novel therapies from cord. So Sorry, that was a little dry list, but it's a lot of goals. So how are you going to do it? What does it all boil down to at the end of the day? So being the UK, we love to create a committee. That committee is going to be, that committee is going to be the UK Cord Blood Initiative. And then what we'll do is divide the work, because there's a lot of it, into a number of subgroups, which, so we're going to have the cord blood banks in one group to ensure that we can harmonise our processes and practices, be that unit report outputs, be that TNC and CD34 thresholds. But it means that everybody in the UK will at least be singing off the same hymn sheet in terms of what we're banking and why we're banking it. Patient selection, I think, is something at the moment, certainly in the UK, that is overlooked. What patients would be suitable for cord early on up front? You know, is there something we could do where we will see a particular patient that we know is going to struggle to find a good quality adult graft, or there's not going to be any donors out there? Can we trigger that selection process earlier for cord and see what options are out there? The CBU selection we've talked about briefly as part of cord support, because that's something we've already done. But again, just to ensure that if someone wants to, they can take up a service and say, these are my criteria, I want this level of match, that much HLA, at least this much CD34, and then say, you do it. And because it's done by a centralized organization, the search and selection process is consistent, it's standardized. Conditioning regimens need to be worked out. That's more on the clinical side, so if Chloe was here, she'd comment on that. But again, it needs to be standardized and formalized so there isn't that center-to-center variation that currently exists. And the same goes for post-transplant care. It's important. It's not just survival curves. We need to ensure that these patients are able to live a full life and not saddled with sort of really brutal GVHD side effects. And clinical trials as well is one part which we're looking at in the UK. Unfortunately, there was some data from some work that Professor Robert Wynne was doing in the UK. It's not quite ready yet, but keep your eye out. It should be published in the next 3 or 4 months, where they were looking at cord blood in minimal residual disease, similar to some of the work that Chloe's done. And the data that I've seen is quite striking in that it really is, as far as he's concerned, the graft of choice. If you've got a patient with minimal residual disease or a previous sort of primary graft failure. So, just to go into some of the subgroups then, as I say, the cord banks, we're going to develop a national consensus on those banking processes, but we also intend to develop a kind of a small fit panel of high quality cords which would be ready to ship at short notice, similar to the NMDP work of the Cure Ready project and what WMDA is working on as well with their ready to ship. But we need to review and update our strategy on cord banking as well in order to look at the number and the quality of units stored, because effectively we need to do the same as the Japanese have done and ensure that that inventory is fit for purpose. Because if you just keep collecting, just keep banking, you end up with hundreds and hundreds of repeats of the same unit that are not necessarily going to be used for transplantation. There's 2 things you can do with that. Those repeat units may be able to be used for cell and gene therapy purposes or clinical trials to work with pharma companies. And then on the other side of the coin, we can make sure that there's no particular ethnicity that's underrepresented within the bank to ensure that we can serve our patients as best as possible. And if not, that's when we're relying on the international community to be able to get high quality cords quickly, because everybody else's unmet need. Patient selection, as I said, we need a strategy for triggering an early cord unit search, realistically for patients that we know are going to struggle to find reasonable quality and well-matched donors. And that we can also do that through kind of checklists to assess the patient and work out whether with their antibody profile and high-resolution typing, whether or not that's something we should be triggering early. There's also work that the clinicians are doing around the pre-transplant workup, the patient eligibility, the comorbidities, and what kind of tests need to be done around organ function and infectious disease assessments to work out whether a cord would be suitable. In terms of search and selection, we need to refresh the guidelines for unit selection. We've got to establish a UK service for all transplant centres to be able to access to simplify that, as I've stated. And we've got to review and update the cord blood unit advisory panel. So just to give you a bit of background on that panel, the British Society for Histocompatibility and Immunogenetics, so BISHI for short, has a panel of HLA experts whom you can say, right, these are my 10 cords that I've got shortlisted. Which one do you think is the best cord and the best match for my patient? But we've recently integrated a number of cord bankers into that service as well. So as well as just looking at match, we can look at things like levels of hematocrit, number of bags, is it red cell replete, what's the hematocrit dose going to look like, so we can give a kind of a more rounded opinion on the units as opposed to just this is your best match with your least HLA antibodies. And the aim there is to provide a rapid service, so ideally within 24 to 48 hours, you should have the answer from the panel. And it should help that standardise that UK approach to CBU selection, but also critically provide interpretation of the CPU data as well. So it's the full picture, it's not just half the picture. So I'll just give you a quick example. We offer a shortlisting service which aims to refine the list. So you might do a search for a patient and it could come up with over 1,000 answers from kind of WMDA search and match or something like that. If TC gives us the criteria, we can whittle that down to a sort of a top 10 based on what their recommendations are. That could be anything from TNC and CD34, obviously, to ensure it meets dose criteria. It could be a particular accreditation that they're after. It could be a particular red cell content that they don't want to exceed. That does mean that we can ensure that the patients are getting the correct TNC and CD34 dose. You'd be surprised at how many times unit report requests come through where they are just suboptimal from the get-go. Sometimes this is because the search and selection has been done so focused on HLA that someone will go, right, I need an 8 out of 8 or a 7 out of 8 match, and they kind of go down the wormhole and they end up with these cords that are actually suboptimal in dose. Whereas if they'd looked at some of the 6 and 5s, the dose is way up there, and also it's still going to be good for their patient. I mentioned that we can take into account other things like accreditation. So certainly in the UK, they'd be keen to see FACT or AABB accreditation if they were looking kind of globally. It just gives a reassurance around the kind of the standard of the data that they're going to get and the reliability of it. We also offer another side of the service here in that we've got checklists that identify any information that's missing early on, because what you don't want to do is get right the way to the point of shipment, then suddenly cancel because you can't get a critical parameter that you're after because you didn't realise that wasn't part of the testing suite of that particular bank. We're just in the process now of updating these checklists. Before it was a simple yes-no list as to whether or not the data was present. But what we're trying to do now is put a rough range on it. And it is a rough range because we've based it on our experience, but we would contact the providing bank if it was kind of outside a range and say, well, is this normal for your inventory? But what it means is it doesn't matter what the unit report looks like when it comes in, it gets standardized into an output. So you'll get the original unit report and you'll get the checklist, and that will go to the transplant center so they can compare apples with apples. In this case, it's showing that it's suitable for single or double cord. It's fine for both CD34 and TNC. There's a little bit of a highlight there on the hematocrit because at 45% hematocrit for that particular patient weight, the RBC dose is marginal at 0.25 mils per kilogram. In the UK, that's where the kind of the threshold for considering washing sort of starts. And we definitely avoid going over sort of 0.4 mils per kilo. And again, there's comments on things like the CFU growth, the viabilities. There's more to it, but I can only squeeze that much on. So it'll highlight any missing virology tests. In the UK, we do split CMV, IgG, and IgM. Other parts of the world, it's common to do CMV total. So again, the report will highlight and flag. If it's a CMV total positive, we need to go back and ask for either IgM results or a CMV PCR. So it just takes the legwork out of it for the coordinators because we're chasing that for them, and then they'll just get an updated sheet. This same sheet will also deal with the post-thaw data once it's in and compare the pre-freeze and post-thaw to look at recoveries of things like TNC and CD34. And again, it can be seen at a glance. We're rolling this out in the next month or so in the UK. Initially, it will start for our transplant centres that work closely with us and have the cord support services. If we can persuade the powers that be that the clinicians like it, we'll try and roll it out for every transplant centre in the UK, which means we'll need to provide about 1,200 of these reports a year. But if you can't do it by the cord bank standardising the unit reports, because that's difficult, then the registry can do it from the other end and standardise some sort of interpretation for them instead. So here's just a case study on search and selection. We had one of our cords was actually requested as a single transplant for an EU patient. The cord itself was a 7 out of 8 match. It had 12 kilos of CD34 dose, and the TNC dose was fine against guidelines as well. The problem was the patient weighed 60 kilograms, so the CD34 was 5 times lower than the recommended cell dose. We ran an internal search as well. We found a number of CBUs at 6 out of 8 match with much higher cell dose and presented those options to the transplant centre. They actually took up one of those alternative options, and they were really happy with it because at the end of the day, what would have happened is best case scenario, a really slow engraftment, a long time in hospital, worst case scenario, graft failure. And that was simply just by dropping it from 7 out of 8 to 6 out of 8. We need to look at how we can help with CBU requests, delivery and handling. So we've got to help facilitate the UK Transplant Centre's ability to request cord units and advise on that quality control data. We need national guidelines on CBU unit receipt, because it's not always a stem cell lab receiving these cords. Sometimes they will actually go straight to ward, and it could be nurses handling these things and thawing them out in water baths. So we need to make sure there's some simple guidance on how to check shippers, ensure there hasn't been transient warming, how best to thaw them out, that kind of thing. And again, guidance, education and on-site support for transplant centres is also critical, because it reduces pushback. Because if got a fairly big transplant centre, may have 50 or 60 ward staff. If they're only doing 5 cord blood units a year, each individual nurse may only thaw a cord blood unit out once every 2 to 3 years. So then when the transplant coordinator says, right, we've got a cord coming in, everybody panics and they all push back and go, no, don't want to do a cord, don't want to do a cord. And that then goes back to the transplant coordinator who has to deal with it. If you offer to turn up on site, who knows how to thaw cords best? Cord blood banks. So if you can work with your local hospitals to support them in that, it just removes the anxiety and removes the pushback. So here's just a quick case study on some of the QC data interpretation. It was looking pretty good. 94% TNC recovery, plenty of CFU just shy of 4 million, clonny of 25%. So we got good viability, good functionality. The problem was the CD34 and CD45 by 7AD wasn't available. They had a problem with the flow cytometry on that day, so they used Trypan Blue, and that came as 48%. So the question we got was, is it all right to use that? So our response was first off to highlight that the recovery was excellent. We've got 4 million CFU post-thaw with 6.9 million CFU post-process, so you've got good recovery of functional units. If it really was only 48% alive, you'd be unlikely to recover that number of functional cells. So we reported back that data back to the TC. We do a little bit of maths and work backwards. If your post-thaw clonny is 25%, then 4 million divided by roughly 25% gives us about 15.8 million stem cells. The original report showed that it was 15.95 post-process. So again, we can say roughly we've recovered most of the stem cells as well. We need to work on a consensus for conditioning regimens. We need consensus protocols nationally. We need guidelines on immunosuppression, dosing, timing, duration, that kind of thing. And we need development of novel conditioning regimens as well. Post-transplant care needs to be looked at, including infection prophylaxis and early post-transplantation infection monitoring, assessment of engraftment and management of slow engraftment, detection and management of pre-engraftment syndrome, graft versus host disease diagnosis, therapy and immune suppression taper, and disease reassessment guidelines. Clinical trials and research are critical. We must ensure that there is development of novel, innovative, practice-changing UK clinical trials. Cord at the moment is often viewed as a second or third line treatment, but research will show that in some cases it should be the first line treatment, and that's what we've got to get out there and publish that and promote the collection of high quality data, because it's only through that data collection that we'll be able to demonstrate there really is a long-term benefit in terms of quality of life, lower chronic GVHD, and also that those costs, the expense that's often cited, it may be expensive, but if your patient doesn't come back, instead of relapsing after 2 years, you've got to look at the long-term costs, not the short-term, oh, my hospital's clear in a month, great, next patient. We don't want them coming back. And we need to facilitate and encourage the basic science and the translational research in cord blood, including development of novel cellular therapies. Education and training is something we've done some of. We need to organise proper national education and training events in order to promote cord transplantation. We need to provide the practical on-site education and support that I've talked about, and also critically develop a training program for junior euclid clinicians and consultants to make sure that there's kind of that mentoring process to continue on cord blood transplantation. So in terms of the on-site assistance, that's where the cord banks can really come in. We can deliver vital expertise at those transplant centres. As I said, ward staff performing thawing infusion are used to large bags, so suddenly getting these little small cord blood units can be a bit of a surprise to them, and they worry because they're small, they think they're fragile. It's made out of the same material. So it's just a bit of myth busting on site. Plasticware is another one. So quite commonly giving sets will have, a spike with a burette, and then there's a 1 metre long tube to the patient. If that's all you've got, your cord blood will half fill the burette, and then there's still a metre of tube. So it's just, again, sometimes going along with samples of plasticware and saying, well, try this little spike, or try this little syringe, or use this cell set, just to make it easier for the teams there. As I say, that perceived fragility of bags is another thing. Once they're thawed out, they're just as robust as any other cell bag. The other area, I suppose, where it's valuable to be on site is if there's any kind of bag damage. So because of cords, when they're transported, you've got that seal between the 5 mils and 20 mils. If they do get knocked about, there can be a possibility of a crack there. But there's nothing, again, to stop you turning up on site with a sterile overwrap bag with some clamps. You can thaw it out with a thumb and finger. You can clamp either side, and then they can carry on with that transplant as normal with a first choice graft. But again, ward staff wouldn't do that. If they've got a stem cell lab on site, they might do that. But in the UK, sometimes the stem cell lab can be disparate and sort of 3-4 miles away. And then you've got a problem of you've thawed it out and then you've got to transport it back to the ward. So it becomes logistically complex. So if you can help and support, great, do it. What I said, there we go. So yeah, it's that support. It's eliminating the concerns around the usage. So here's a quick case study for you on this one. We had a UK TC that hadn't used cord for about 10 years, in fact, and then needed to do a double cord transplant with 2 cords. So all we did was we went across with some dummy bags and a cryoshipper. We got a selection of spikes for them. So literally the clinical team could have a play with it, decide which spike they liked the best, and allow them to become familiar with the process before going into the room with the patient to do it for real. It also allowed them to refresh their SOP and kind of make some changes and tweaks based upon what was available now compared to then. We also said that we would turn up on the day of the transplant. There wasn't particularly anything for us to do. We just sort of stood there and, they're like, am I doing this right? Is that thawed out? It's just a confidence boost. But that receives really good feedback. And this centre is now a regular user of cord, having not used any at all in a decade. The last area, although not covered by the group, is something we do and anyone can do, is ad hoc queries. We get all sorts of funny questions like, should it look like that? And it'll be 3 different colours, which is like, no, because the DMSO should be actually mixed with the rest of the cord blood. Go get another one. We get questions about the benefits of washing for low-weight patients versus the loss in cells. But if you've got a paediatric patient, by and large, cord's going to have plenty in there, and the losses from cell wash will be relatively minimal. As we said, advice on acceptable red blood cell per kilogram limits, impact of transient warming events, if there is any, segment thaws that we've done as well. So we have actually thawed segments from cords from other labs because they're like, we've got this data, we're not sure it's right. Could you repeat that for us? So here's a quick case study on this one, nearly there. We had 2 cords shipped for a UK transplant centre. Because it was urgent, they were shipped prior to the completion of the CFU assay. One of the units had slightly lower CD34 viability and didn't actually produce any colonies. So we got them to send the last segment across from the unit, and we basically performed the release testing as we would for one of our own cords. That showed a very low viability by annexin, so there were a lot of apoptotic cells, which meant we were unlikely to see CFU growth. So as a result, we got the team down in London to do a search for an alternative cord. We managed to find some good 6 out of 8 match, which was procured as a replacement. And that patient actually underwent their double cord transplant with no delay. That's me done. Has anybody got any questions?
Hey, Roger, very nice talk. I'm Patrick from EMA Quebec. So I think the effort that you've done really show a great effect in what you've shown with the graphs and all, so congrats on that. And if you want to adopt some Canadians, just give us a call, right? We'll be more than happy to help you out.
I tell you what, next time some units go over to Canada, I'll recommend you. You can help in your local area.
Thank you.
Well done, Roger. I have a couple comments. First of all, thank you for helping the rest of the cord blood banks out by training clinicians. That works out very nicely. Also, Yanni Politicos has, and the NMDP and CIBMTR have selection guidelines that are very consistent with each other and would be great. We can get you copies of those if you like for some of that standardization. So I was curious in the Japan banks, I wonder if they can limit their bank to 10,000 because of their diversity. I think it might be a little bit more of an issue in the US, the UK, with the heterogeneity of the population. So I wonder if maybe that isn't a factor that we need to put into thinking about the size of the inventory.
Totally agree.
And go ahead, Rudy.
No, as you say, I guess it's about making sure your bank is fit for purpose. So what we've tried to do in the UK is, for want of a better phrase, look at ethnicity buckets and how many cords have we got in each bucket. And if we've got too many repeats over here, let's do something else with those. And then we've actually launched a translation project. So some of the donors that we can't currently consent because they're not their first language isn't English. We've looked at the 5 most common non-English languages at our transplant centres in order to enable us to get into those populations that traditionally we wouldn't have been able to collect from. There's also possibly on the horizon the idea that if you have got some cords of useful ethnic background, you could actually expand those, pre-expand them, split them, and then bank them. So you can boost your inventory that way potentially.
So my only other comment is about post-thaw testing. I think that's very, very difficult for transplant centers to understand and to be, whether to provide the results or not without context, it's not helpful and can cause anxiety. I think that should be something we all work on to standardize. What does it mean? You're not going to get 100%, and you should be suspect if you see that, right?
Yeah, no, agreed. Post-thaw data is, if you've got one piece of data that's off, that shouldn't necessarily put you off. You need the context of all the rest of the data with it. It's not something you can just do in a flat algorithm that says, if data point X is below that, don't look at it. It doesn't work.
I hate seeing cords deferred because of one aberrant piece or a misunderstanding by the
Absolutely. Juliet?
A couple of things. Yanni Politicus and I wrote the cord blood selection guidelines together on behalf of our group for the ASTCT cord blood seg. And I'm having flashbacks because we wrote them in spring of 2020 in New York when we thought everyone was going to die. It was quite the experience. So I sat in my apartment in Harlem and just listened to the silence and all the sirens as the hospitals collapsed. So the unit selection guidelines for ASTCT is going to have a special place in my memory, but the value of us all sitting there writing these guidelines for ASTCT in 2020 is that we've got this kind of body of work for a group of transplant physicians that are very dedicated to work together. And what we're doing now is that we're actually, they were all published in BBMT, but they're kind of like little kind of reviews, if you like, and they're too long. So you have to sort of read it all to sort of digest it. So what we're doing now is that we're taking those guidelines and condensing them down into like a tiny little package, if you like. Like each guideline, which is a sort of like a chapter or a paper, is ending up being like 1 page. Or 1.5 pages at the absolute most in an average Word document, and we're going to create a package that you could basically just send somebody, and it would be like sort of, here's how to do a cord blood transplant for, say, an adult with heme malignancy, just here it is. And you just sort of open it up and there's 10 pages and it's just like, just do it like this, almost like a recipe, like a sort of cookbook. And, all the list of all the stuff well, not all of it, but quite a bit of it, that you said, okay, we need all of, we need this. That's what we're trying to do now, because the need in the United States is exactly the same. So I just think that there's a lot of opportunities to collaborate here. And, there's certain things, as I was listening to you, sometimes there's some particular aspect of what you were talking about, there may be one or two ways to do it, but there's a couple of things that rang out that was definitely, you just don't do it like that. It won't go well. And trust me. So, I think having the transplant physicians be sort of front and center, because they're the ones that are always at the bedside much more than the banks. I mean, I appreciate what you're saying about the thora and the tubing and all of that type of stuff, absolutely. But there's a lot of other aspects that it's just, just ask us kind of thing. And the other thing is that the histocompatibility people, from the adult donor, the brain is that histocompatibility is the most important. But for us, it's actually, at least when we're transplanting the adults for heme malignancy, it's the least important. It's like we just go way down on the mismatch. So we do quality first, CD34 dose second, and then the sort of HLA match is sort of third on the priority. And you might not get that from someone who lives and breathes histocompatibility. So that has to be taken into account. Thank you.
No, absolutely. Couldn't agree more. You've got to have the perspective of the end user, and you've got to allow the groups to work together. Boiling down the information to the salient points is also key. We've tried to actually do that on our unit report. So we have a page that we created about 18 months ago that uses both the UK guidelines and the US guidelines. It's a quick reference table. Patient weight goes in at the top of the report, and then it calculates whether or not it meets criteria dependent upon patient weight and country. And it's literally a quick table, and it's either red or green, and you know whether you can use it for single or double transplant, and whether you can use it, it's got to be 6 out of 8 match, or you can go lower than that. And it's getting those key points across in a really simple way, so you can just go, that one's good, that one's not, that one's good, that one's not.
Guy Clay, I'm a Sydney Cord Blood Bank from Australia, the chair of our networks here, so I hope I'm not running out of my lane. Don't like asking questions, so I've written it down. Thank you to Anthony Nolan for modelling all of the addressing absence of support, loss of skills, very relevant to the Australian situation. Glad to ask the last question, because we've had a Canadian colleague saying, I want to do it, a transplant physician saying it's really important, Donna as well. So here I am saying the same thing. But my question is, how does the International Cord Blood Bank Network, we've spoken about this and we'll grab a coffee, scale this up so there is support for transplant centres anywhere in the world, regardless of who shipped the unit? We're all different based on where we are. Australia is very far from everywhere, so a cord coming to Australia could be supported in that time zone and vice versa when we ship. The number of transplants have gone down, and I'm rambling a little bit, but there's 4% of the global public inventory in Australia, so it's still like a pretty big piece of the puzzle. What I'm getting at is, the second part of the question is it possible to scale this up and be involved without the local registry?
So, absolutely. What I would say is, and this is a plan in our head at the minute, it's not concrete, but what we're looking to do is to have, ideally, international affiliates that can do a similar thing that we can do. So the idea would be that if a UK cord went abroad, hopefully a local cord blood bank near the hospital that's getting that stuff delivered can offer some of the same services on site. Certainly kind of the help with thawing and infusion, things like that. That can be done without the registry's involvement, because you should hopefully have a relationship with your local hospital. And if not, go down there and introduce yourselves and say, hi, we're a local cord blood bank, we can help you with this, 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 and this. If you get any weird results, give us a shout, we'll thaw you a segment, we can compare data. So absolutely, you can do that. if you've got the registry on board as well, then maybe you can pull in some of their expertise to help with the search and selection stuff. But anything you can do to help alleviate stress for the end user is absolutely to be commended and to be done. So I really do urge you, get out there, talk to your local transplant centres and try and work with them. And we'd be just as happy to work with you and show you some of the materials that we use for the training sessions that we deliver. Quite happy to do so. It'd be great if we could create an international network, as you say, of affiliates that will do cord support wherever a cord's going.
So it'd be great to take that next step and collaborate between different regions in the world to make that happen in a very practical way that's easy and cheap.
Absolutely. And I think we can also kind of get the registries on board in that as well, because it's an additional service that the registries can help offer and orchestrate as well. Because whereas we can kind of maybe talk to our local centres, they've got a broader reach than we have to make it national and get more people involved. Because it's as big a risk to cord the loss of expertise or this perceived difficulty is just as big a risk as anything else. We've seen it ourselves in that, you know, a hospital that was one of the biggest users of cord in the UK, a clinician retired and the usage dropped off a cliff edge overnight because there was no mentoring, there was no additional support.
Great. Yep. Thank you.
All right. If there's no further questions, I'll draw it to a close. Sorry, I've kept you from your lunch for 10 minutes.